Hi, everybody, and welcome to our module on maternal-fetal disorders. Let's start by talking about ectopic pregnancy. An ectopic pregnancy is a pregnancy that occurs outside the uterus. And 98% of ectopic pregnancies occur in the fallopian tube. As you may know, fertilization usually occurs in the fallopian tube, and in an ectopic pregnancy, basically the fertilized egg doesn't move any further down the fallopian tube and it doesn't get to the uterus. Most commonly, these pregnancies occur in the ampulla, which is the mid portion of the fallopian tube. The ampulla is this fat portion here before this skinnier portion, which is called the isthmus, and right here is where most of these ectopic pregnancies occur. There's not much room for the embryo to grow in the fallopian tube, so this usually leads to symptoms in the first trimester of pregnancy. The symptoms can include vaginal bleeding. There also may be abdominal pain that sometimes mimics appendicitis, and anytime a woman presents with acute abdominal pain, one of the mandatory and standard blood tests is to check an HCG level to see if she could be pregnant. And then finally, if you check serum HCG levels, you will find that they rise slower than normal in an ectopic pregnancy. So usually the HCG level in a normal pregnancy rises in a steady fashion through the first few weeks. What you'll see in an ectopic pregnancy is that it will not be rising at all or rising at a much slower rate, usually with generally lower levels, and that's because the placental tissue is not developing normally in the fallopian tubes. Ectopic pregnancy is usually diagnosed by ultrasound. This is a picture of how an ectopic pregnancy looks by ultrasound shown on the screen here. And the treatment is often with surgery, although sometimes the drug methotrexate can be used. Methotrexate is a folate antagonist, and I talk about it in more detail in the videos on chemotherapy in the hematology section. But if an ectopic pregnancy is relatively small, then sometimes methotrexate is given. It will disrupt folate metabolism in the embryo, and sometimes the tissue will simply pass without surgery being required. So as we discussed earlier, if you have an ovary here connected to the fallopian tube, ectopic pregnancies occur when the fertilized egg gets stuck here in the fallopian tube. And if you understand that, then it's very easy to understand the risk factors for ectopic pregnancy. Anything that results in damage to the fallopian tube can lead to scarring and prevent the fertilized egg from being able to move down towards the uterus. So one major risk factor is a prior ectopic pregnancy. Once you've had one, there's damage to the fallopian tube and you're at risk for another. Other risk factors include tubal disorders. So if you've had a tubal ligation, which means that your tubes have been cut, or sometimes is referred to as being tied, so that you won't get pregnant. If you do happen to get pregnant, it will usually be an ectopic pregnancy. So it's rare to have pregnancy after you've had your tubes ligated. However, it sometimes occurs, and when it does occur, it's almost always an ectopic pregnancy, because the tubes have been surgically damaged. If you've had any prior tubal surgery, for example, to remove a tumor, that raises your risk of an ectopic pregnancy. And then finally, pelvic inflammatory disease caused by either chlamydia or Neisseria is a major risk factor for ectopic pregnancy. In this disorder, bacterial infection occurs in the uterus and the fallopian tubes, and naturally that can leave scar tissue behind that sets a woman up for an ectopic pregnancy. Some other risk factors are shown on the screen here. Women who are infertile for any reason have a higher incidence of ectopic pregnancy. The reason for this association is not clearly understood. And then finally, Cartaginer syndrome, which is a consequence of the rare disorder primary ciliary dyskinesia, can result in an increased risk for ectopic pregnancy. In this disorder, women have a problem with cilia. This often leads to lung problems because they cannot clear mucus, but it also leads to fallopian tube problems because the fallopian tubes contain ciliated epithelium. Therefore, these women have difficulty moving a fertilized egg down the fallopian tubes, and they're at higher risk for ectopic pregnancies. Now let's talk about spontaneous abortion, which is also called a miscarriage. This refers to pregnancy loss before 20 weeks. Pregnancy loss after 20 weeks is usually referred to as a stillbirth or fetal demise. Spontaneous abortion usually presents in the first trimester as vaginal bleeding. It often requires a surgery called the DNC to remove all of the fetal tissue. And you should be aware for step 1 of your boards that 50% of cases are due to fetal chromosomal abnormalities. We talk about Down syndrome and other chromosomal abnormalities where the baby can grow to term, but there are many other chromosomal problems where the baby will not grow normally and it will simply die in utero, and it will present as a spontaneous abortion in the first trimester. Some risk factors for spontaneous abortion are shown on the screen here. First of all, if the mother smokes, drinks alcohol, or uses cocaine, there's an increased risk that she will lose her baby, and I talk about all these things in the videos on teratogens. If a mother develops any of the torch infections that are dangerous during pregnancy, this can lead to spontaneous abortion. Hypercoagulable states increase the risk of miscarriage. That's because thrombus can form in the placenta and lead to loss of the baby. And in particular, women who have lupus and the antiphospholipid syndrome often have recurrent spontaneous abortions. And in fact, when a woman is being worked up for infertility related to multiple pregnancy losses, one of the things that has to be considered is that she may have lupus and the antiphospholipid syndrome. Sometimes this goes undetected until a woman has multiple pregnancy losses. In the next few slides, I'll talk about problems related to amniotic fluid. So the primary source of amniotic fluid is the fetal urine, with a little bit of extra fluid coming from lung secretions. The major source for removal of amniotic fluid is fetal swallowing. So if you know this, then it's easy to understand that oligohydramnios, which is decreased amniotic fluid, occurs when there is a fetal kidney problem. And polyhydramnios, which is excessive amniotic fluid, occurs when there is a swallowing or GI tract problem. Let's talk about oligohydramnios first. This can happen when there are fetal renal abnormalities. For example, if the kidneys fail to form in the baby, this is called bilateral renal agenesis. This can lead to oligohydramnios. Obviously, the baby won't produce sufficient urine. In addition, male babies are sometimes born with tissue that obstructs the urine flow in their urethra. This is called a posterior urethral valve, and this can potentially lead to oligohydramnios. And I talk about both of these things in more detail in the renal video on renal embryology. Oligohydramnios can also be seen when there is any form of placental insufficiency. Remember that the placenta supplies nutrients and fluid to the baby, so if there is insufficient blood flow to the placenta, then the baby won't be getting enough fluid. It's basically like the baby not drinking enough, so obviously it won't produce much urine. So you can see oligohydramnios in the setting of preeclampsia and other maternal vascular disorders. And then finally, you can also see oligohydramnios, especially in the third trimester, if the membranes rupture. If they rupture prematurely, when you do an ultrasound, you'll see decreased fluid, and that's because the membranes aren't intact. And anytime you have oligohydramnios, that can potentially lead to Potter sequence, which I also discuss in more detail in the renal embryology video. Potter sequence is what happens when there is oligohydramnios and the cushioning of the fluid is lost, and therefore the baby is vulnerable to external forces from the mother's abdomen. This can lead to compression of the fetus and potentially cause limb deformities and a flat face. It can also lead to pulmonary hypoplasia. Now let's talk about polyhydramnios. So as I said before, anytime there is a fetal swallowing problem, this can lead to polyhydramnios. So for example, babies that have esophageal or duodenal atresia do not have a fully formed GI tract, and therefore they will have difficulty swallowing the amniotic fluid. Also, babies who have anencephaly, which is a central nervous system disorder, can lack the neurologic function to swallow the amniotic fluid, and they can develop polyhydramnios. If the mother has diabetes in pregnancy, the baby can develop hyperglycemia, and this can lead to polyuria the same way that hyperglycemia in an adult leads to polyuria when adults have poorly controlled diabetes. Fetal anemia is another potential cause of polyhydramnios. This leads to high fetal cardiac output, and thus there is more perfusion of the kidneys and increased urine output. And this classically occurs in parvovirus infection, which I talk about in the video on porch infections. And then finally, when a woman has a multiple gestation pregnancy, for example, twins, there are obviously more kidneys producing urine in utero, and therefore there is more fetal urine, and you will see polyhydramnios when you image the abdomen. Now let's talk about low birth weight. The definition of low birth weight is a baby that is born less than 2,500 grams, which is 5.5 pounds. This is often caused if the baby is delivered prematurely before it has grown fully to term. It can also be caused if there's any reason for intrauterine growth restriction, which basically means that the baby does not grow to normal size. And babies that are born with low birth weight are at increased risk of neonatal mortality. They're also at increased risk of a number of complications, which we'll talk about in this video. So the bottom line is that any time a baby is born with lower birth weight, there's a greater risk of many forms of complications for the baby. So before we talk about the complications for the baby of low birth weight, let's talk about some of the risk factors. So if the baby has any congenital abnormality, it may not grow to full size, and it can be born with low birth weight. In addition, if the woman has a multiple gestation pregnancy, meaning twins or triplets, each baby will be born smaller than average, and the babies can be born with low birth weight. And then finally, there are a number of maternal conditions that predispose to low birth weight. And the easy way to remember these is to remember that the placenta is the food for the baby. So if you have any condition in the mother that causes the placenta to not be perfused normally, this can lead to a low birth weight baby. So for example, in preeclampsia, there is placental compromise, and this can lead to a low birth weight baby. Obviously, if the woman has abruption of her placenta, the baby will not get enough food and will not grow to full size. And then alcohol, smoking, and cocaine are all associated with low birth weight babies. Alcohol is a toxin, and smoking and cocaine decrease the blood flow to the placenta, so all of these things can lead to a low birth weight baby. So what are some of the problems that newborn babies encounter if their birth weight is low? First of all, they often have hypothermia. They have less white adipose tissue, which is used for insulation. They also have less brown adipose tissue, which is found in babies and is useful for heat generation. In addition, they have a large ratio of surface area to size, so they lose heat easily. So for all of these reasons, maintaining a normal body temperature is often difficult for babies that are born at a low birth weight, and they are often kept warm in a nursery for several weeks until they get a little bit bigger. Newborn babies often have hypoglycemia. When they are born, they lose the maternal source of glucose, and they aren't developed to a significant degree in order to be able to generate their own blood sugar, so they can have hypoglycemia. And then babies can also have hyperbilirubinemia. I talk about this in the video on bilirubin in the GI section, but newborn babies have an increase in unconjugated bilirubin, especially when they are preterm, and this can lead to newborn jaundice. Newborn babies often develop respiratory distress. There are a couple of mechanisms for this. Newborn babies may have neonatal respiratory distress syndrome, which is caused by a deficiency of surfactant. There's also a condition called transient tachypnea of the newborn, which is caused by inadequate lung fluid clearance. In addition, newborn babies are vulnerable to pneumonia, and through any of these mechanisms, they can potentially develop respiratory failure. And sometimes babies that have a very low birth weight need ventilatory support until they get a little bit bigger. In addition to lung problems, another reason that newborn babies that are low birth weight or premature can have hypoxemia is because of something known as persistent fetal circulation. So in the cardiology section in the video on embryology, I talk about the fetal circulation. And in utero, babies have a very high pulmonary vascular resistance. Their lungs are filled with fluid, and this drives blood away from the lungs and through shunts to the systemic circulation. So for example, in utero, babies have lots of blood flow across the ductus arteriosus and across the foramen ovale. Now, at birth, there is oxygen to the lungs, and the pulmonary vascular resistance should fall, and blood should begin flowing through the pulmonary circulation. However, in persistent fetal circulation, the pulmonary vascular resistance remains high. This means that after birth, babies continue to shunt blood across the ductus arteriosus and across the foramen ovale, and this leads to hypoxemia. There are a number of reasons this can happen. They are all associated with abnormal development of the pulmonary vasculature, and all of these problems are more common in premature or low birth weight babies. These babies sometimes have small blood vessels in the lungs. The blood vessels can have thickened walls, and there can be excessive vasoconstriction. But the primary problem here, and what you want to know for step one of your boards, is that if babies have hypoxemia at birth from persistent fetal circulation, it means that they have persistently elevated PVR, and that is causing them to shunt blood and develop hypoxemia. Another reason low birth weight babies can develop pneumonia is because they have impaired immune function at birth. Their cellular immunity is usually impaired, and they have less T cells and B cells compared to normal babies, and some premature or small birth weight babies are also born with neutropenia. Polycythemia of the newborn is a condition that can happen to low birth weight babies. This is an excessively elevated hematocrit at birth, usually greater than 65. One thing you should know is that newborns normally have an increased red cell mass. The fetus is a slightly hypoxic environment in utero, so this drives production of red cells and hemoglobin. And in addition, the placental blood at birth may transfer to the baby, so you can imagine that placenta normally holds lots of blood, and then when the baby's born, all that blood rushes back into the baby, and this can temporarily and slightly raise the hematocrit. This can happen to a greater degree in babies that are low birth weight because they don't have a lot of a volume to tolerate that increased red cell content. Usually this is asymptomatic, but in rare cases it can cause symptoms like hypoglycemia from excessive red blood cell glucose utilization, or rarely hyperbilirubinemia from more breakdown of the red cells. Low birth weight babies are also at risk for necrotizing enterocolitis. This is an intestinal condition where the baby develops intestinal necrosis and obstruction, and I talk about this disorder in more detail in the GI video on intestinal disorders. Necrotizing enterocolitis usually occurs in the terminal ileum or colon, and it can lead to perforation, and the major risk factor for this condition is premature birth or low birth weight. Low birth weight babies are also at risk for a special type of cerebral hemorrhage called intraventricular hemorrhage. This is hemorrhage into the lateral ventricle, and I talk about this disorder in the neuro video on intracranial bleeding. It is a special type of intracranial bleeding that occurs in low birth weight babies. These babies will develop hypotonia, they will develop a loss of spontaneous movements, and they can develop seizures and coma. And what you want to know about this disorder for step 1 is that it is a problem with the germinal matrix. This is a highly vascular area near the ventricles, and in premature or low birth weight infants, there's poor autoregulation of blood flow in this section of the brain. In full-term infants, this area has decreased vascularity, so therefore it's not at risk. So because the germinal matrix is underdeveloped in low birth weight and premature babies, they are at increased risk for this special type of CNS bleeding. Low birth weight babies are also at increased risk for SIDS. SIDS is the sudden infant death syndrome. I'll talk more about it in a second. But for now, just know that it is the leading cause of infant mortality between 1 month and 1 year of age in the U.S., and there's a higher risk of SIDS if a baby is born preterm or with low birth weight. And then finally, children with low birth weight are at increased risk of neurocognitive problems later in life. Compared to children of normal birth weight, there is a higher rate of problems with cognition, social skills, and behavioral and emotional skills. I'll finish with this slide on SIDS. The definition of SIDS is the sudden death of an infant less than 1 year of age that is unexplained by other causes. For reasons that are poorly understood, a small percentage of children die suddenly at less than 1 year of age, usually in their sleep, and that is SIDS. Risk factors include allowing the baby to sleep on its stomach. New parents are advised to have babies sleep on their back to reduce the risk of SIDS while the baby is sleeping. If the mother smokes during pregnancy, the risk of SIDS is higher compared with when mothers don't smoke. Mothers who are very young when the baby is born, less than 20 years of age, have infants with a higher risk of SIDS. If the infant and parents share a bed, the risk of SIDS is higher. And then finally, if the baby is premature or has low birth weight, the risk of SIDS is increased. And that concludes our video on maternal and fetal disorders.